Hello, everyone, and welcome to Biohackers Lab. I'm your host, Gary Kerwin, and on today's episode, I have Dr. James McCarter. Dr. McCarter is an MD and PhD who is the head of research for Virta Health and is an adjunct professor of genetics at Washington University School of Medicine. He is also an experienced biotech entrepreneur and a keen quantified self follower. Jim, thanks so much for coming on to the show today.
Gary, glad to be here.
So my main sort of topic I want to talk to you about today, because there's so many things we can talk about, especially with your history in the quantified self and the biotech and now with Virta Health. But it's more the Virta Health I want to talk about today. And really the question is, do online diabetes prevention and reversal programs work? So if you could just explain to the listeners, what is Virta Health?
Sure. So Virta Health has established the first online diabetes reversal clinic. And so the treatment we provide involves 5 things. So it's telemedicine support from a physician. It's online nutrition and behavior change education. It's access to a health coach who's trained in nutrition and behavioral support. It's biometric feedback, and as well as an online community. And so by providing entirely in a remote setting that wraparound intervention, we've shown in a clinical trial that we can reverse the effects of type 2 diabetes.
Yeah, so there's a lot going on there, that a lot of support structures, it sounds like. It's not just one person, it's a physician and a separate health coach. So there's 2 different people involved in that.
Yeah, so we find that the thing that's really important with asking someone to make a major behavioral change is to provide that adequate support. And so the different features provide, different things. And so let's talk about kind of what the doctor does and what the health coach does. So the doctor, we have internal medicine and endocrinology doctors that are licensed in all 50 states in the United States. They're Virta employees, and they have long experience with what we do, particularly in the area of diabetes medication management and in nutritional ketosis, which I'm sure we'll talk about over the course of the interview. And so our doctors are really experienced in this process of titrating medications as people make nutrition and behavior changes. And so the physicians are doing a history early in the process through telemedicine. And so they're establishing that connection with the patient. They know any idiosyncrasies or comorbidities that they're challenged with in terms of their health. And then they can check in usually every couple of months to see how the patient is doing. Now, the health coach has really the day-to-day contact. And so that's largely done using an app interface that allows text messaging between the health coach and the patient. And they'll occasionally jump on the phone if needed. They do a call early. And then they can do, a call every couple of weeks if they need to. But most of their interaction is through texting. And that actually is pretty heavy, especially in the early parts of the treatment. It can be, it averages about twice a day between the health coach and the patient.
Wow. So that is a nice thing here. What I'm hearing is that it's kind of like what even people listening to the show will do, is that they'll be listening to information and then deciding if they should or shouldn't do something. And especially when it comes to changing diet and trying to make their metabolism healthier and not get to reduce the risk or manage their diabetes better. And in this case, the benefit they're getting from Virta is that they get the medical oversight component to this, so they get that medical care, but then they're getting that daily support for someone to go, you're making the right decision, or I know you're struggling with this today, this is what we recommend. That kind of daily support to, as you said, to create that behavioral change.
Right. And so it can be things like factual information, like nutrition information in terms of understanding ingredients or restaurant menus or things like that, where I'm going out for dinner this evening. Can you help me in terms of what I might select off the menu? It can be as basic as that. It's emotional support. It's knowing that somebody's there who's going to consistently be caring for you, and whether you have a good day or a bad day, whether you fall off track or are staying on track and doing really well, you have somebody there who always can be supportive of you. And then also the health coach is the conduit for flow of information with the physician. So when there's a change to a medication, the health coach acts as the communicator between the physician and the patient to titrate medications.
Okay, so because that is another goal of the company, I guess, is that you're trying to reduce the unnecessary use of diabetic medication to tear people off, to wean them off if they can.
Yeah, so there are many benefits of getting off medication. First is just you shouldn't be using a medication if it's not needed, and so if there's no longer the need for a glycemic control med, then there's really no sort of justification in continuing it. But the benefits are many. First is avoiding hypoglycemic events, particularly insulin and sulfonylureas can cause people to bottom out in terms of their blood sugar, which can be dangerous. And so just removing medications of concern like that is a tremendous benefit to a patient. You're removing any chance of adverse events or side effects from the medication. And then you're helping out tremendously in terms of cost, both for the patient as well as for the payer that might be an insurance company or an employer. But many patients will tell us, the out of pocket costs for my medication were running over $1,000 a month. And so, it can come down to paying bills for the household versus acquiring the medication. And so being able to eliminate those costly medications is tremendously helpful to people.
Wow. So in the US, if you're diabetic, your out-of-pocket cost could be $1,000 just for the medication side of things.
Yeah, it varies depending on the severity of the diabetes and the degree of medication, but the branded insulins can be quite expensive. Mm-hmm. Also, branded GLP-1 and SGLT2, those medications can be quite costly. So we find that for patients who are heavily medicated for their diabetes, the cost of their medications can average about $5,000 a year, and we can on average eliminate about 3,000 of that on the population as a whole, and that's based on our clinical trial results. But there are outliers who have these enormous bills of over $12,000 a year on medications. And depending on how their health care is structured, a lot of that can be out of pocket.
Yes, that's just another side I don't particularly think of. When you think you're diabetic management, it's more from I don't want to lose my toes or get other complications, but just I guess the immediate effect that most people will start feeling is in their pocket is the loss of money, going, wow, this is expensive, this health condition.
Yeah, there's a great anecdote on that. Mike Halley is one of our patients not in the clinical trial, but one of our commercial patients. And he tells that story in an interview with Rock Health. So if you just search for, Rock Health and Virta, you'll find Mike's story. But he's one of those people who had that enormous medication cost and enormous medication savings that accrued to him as he had success.
Hmm. So we've been talking about people who are using the service. Are they referred to as patients or clients in this case?
We use the term patients, and in terms of reflecting the medical nature of what we do.
Mm-hmm. And is it only based in? Is it only for US based people, or could anyone from around the world access the system?
Right now, it's the United States. So if you go on the Virta website, you'll see that we have laid out an ambitious goal, incredibly ambitious goal of reversing type 2 diabetes in 100 million people by the year 2025. And so, of course, that will involve an international effort eventually. There are about 400 million people with type 2 diabetes worldwide, about 30 million in the United States. But for now, we're focused on getting the intervention proven, which we've done, showing that it works commercially in the United States, and then eventually we'll be able to expand beyond the United States.
And so this is only for type 2 diabetic patients at the moment who have been diagnosed with type 2 diabetes?
Yeah, so what we do with folks, and there are a couple ways in which people come to us, but we do work with people with type 2 diabetes with prediabetes, as well as obesity and metabolic syndrome. And what we see in terms of the benefits for folks on Virta is not only a benefit in terms of improvement in their symptoms of type 2 diabetes, but also improvement in their cardiometabolic risk factors, improvement in markers for fatty liver. And so we have a paper in press on the cardiovascular outcomes with the Virta trial. And we've submitted a paper on the fatty liver outcomes of the trial as well. So there are these benefits that, as you know, with metabolic syndrome, a lot of these things kind of travel together. Mm-hmm. And so we don't restrict ourselves to just treating people with type 2 diabetes, although that is, kind of our flagship outcome and focus.
Okay. Yeah. So I think that's good for people to hear, because they might think, oh, I haven't been diagnosed with type 2 diabetes, so maybe I can't benefit from it, but it sounds great to have all this care. But you're saying if you are concerned that you have some sort of metabolic issue, syndrome, that they could contact Virta?
Yeah, please do. That we at virtahealth.com, you'll see links for a direct-to-patient or direct-to-consumer offering, and you can just sign up and fill in that form. It'll result in a call with an intake specialist who will walk you through whether or not you qualify for the Virta clinic. And then it'll sort of take you on from there in terms of explaining the offering. The other thing we're doing, and where most of our patients actually come from, are through employers. And for Fortune 500 companies and other large institutions in the U.S., they're responsible for about half the medical care cost in the United States, the other half being, largely government. And so for those employers that are large enough, they will self-insure, and they will be responsible for their own risk pool rather than using an insurance company as the risk provider. Mm-hmm. And so that employer, and we've announced relationships with Purdue University and with Nielsen, the analytics company. We have many others that are not yet announced that we've begun. And those employers are on the line for the full cost of everyone in their employee and in their benefits pool with type 2 diabetes, which can be, $12,000 a year or more, versus if they can remove those diabetes associated costs, they can, substantially reduce their healthcare spend. So that's where most of our patients come from, is through those employer relationships.
So have you contacted PepsiCo and CocaCola yet?
That's a great question in terms of how not only Virta Health, but this whole kind of movement, and I'm sure we'll get into this more, of demonstrating that type 2 diabetes and diseases associated with insulin resistance are reversible. Mm-hmm. And the largest tool we have in terms of reversing those diseases is a reduction in carbohydrate intake, particularly refined carbohydrates like processed foods, starches, and sugars. And I think you're seeing this already in terms of the food and beverage industry. There's already underway a reduction in the consumption of sugary beverages. And so it'll be interesting to see kind of how innovative do these companies want to be that are perhaps on the wrong side of this issue. Are they going to be innovative in terms of looking at opportunities like Virta to improve the health of their employees, or will they drag their feet and be late adopters? I think it's too early to say, but my suspicion is that one or more of these companies that perhaps are associated with, some of these products that we're showing are not the best for consumers, that they'll eventually come around.
Well, money dictates things at the end of the day. So if they see a substantial saving for the company, I'm sure that would be a major driving factor for them. Yeah. So I guess if we haven't explained yet to listeners, we've already been talking about health and modifying health for diabetes, but people are going to ask now, so what is the diet that Virta will put me on? Is it a specific kind of diet? Is it classified as something?
Yeah, so what we use is a vehicle, a nutritional vehicle called nutritional ketosis. And I know you've talked with other guests about this issue on your podcast, but just to kind of break it down for people, one way to think about diseases of insulin resistance are that with the typical American diet and typical Western diet, we find ourselves on a glucose insulin roller coaster. We eat high carbohydrate meals, meaning that over half of our calories typically come from rapidly digestible carbohydrates. And so what that leads to is a sudden spike in glucose in the blood. And then the pancreas secretes insulin in response. So, the role of insulin is to get the glucose out of the bloodstream, either into muscle or other lean tissue for energy, or to get it into adipose tissue into fat storage. And so you get this glucose spike after a meal, followed by an insulin spike to respond, and then the glucose will bottom out, and you get in this glucose insulin roller coaster. And what that tends to lead to is hunger and cravings, so that you find yourself perhaps an hour after breakfast being hungry again after having something like toast and a banana. And so if you can reduce the carbohydrate in your meals, the first effect that has is that instead of having this high glucose insulin roller coaster, that you can level that out somewhat, and resulting in reduced hunger and cravings, and reduction in the impact of insulin resistance. So that's kind of the quick answer. There's a lot more going on biochemically. And the reason it's called nutritional ketosis is that instead of relying on only or largely on carbohydrates as your fuel source, by reducing the carbohydrates in the meal, you're shifting to a reliance on fat. And those fatty acids can be coming either from the diet, from fat in the meal, or especially in the early stages of when someone is obese and is coming to us and is interested in weight loss, that can be coming from body fat stores as well. So those fatty acids, either from diet or body fat stores, get used for energy throughout the body. But they also are converted in the liver into smaller chain molecules called ketones, so beta-hydroxybutyrate and acetoacetate. And those can be used as a fuel source as well, particularly by the brain, since fatty acids don't cross the blood-brain barrier. It's really the ketones that become the alternative fuel to glucose for fueling the brain. And so that's why we call it nutritional ketosis.
Okay. And so it does sound like that you're able to help coach people into a sort of a medically approved or monitored low carbohydrate ketogenic diet for both weight loss and weight management, but then general metabolic health is what I'm hearing.
Yeah, that's right. And we see actually these benefits across the board when we do this. So not only do we see weight loss and improvement in glycemic status, so reduction in glucose, fasting glucose, reduction in hemoglobin A1C, actual reduction in insulin, but that other factors are changing as well. So dyslipidemia tends to resolve, blood pressure tends to be reduced, and we also see reductions in inflammation. And so one of the reasons for this is that we're improving insulin resistance, but also ketones are now known to act as hormones and have signaling properties that reduce both oxidative stress as well as inflammation. And so this has been shown in a number of studies now, that white blood cell count and C-reactive protein markers of inflammation will be reduced as well.
So are you tracking all of these kind of factors when a patient onboards and goes through the system? That are you doing sort of a blood analysis on everyone, or getting them to do home testing themselves for different levels or factors, or DEXA scans? Is there sort of other imaging or testing that happens when they start the system with you?
A great question. So let me talk first about what we do commercially, and then I'll talk about the clinical trial. So the short answer is that there are a few things that we do commercially, and there's much more that we do in the context of our clinical trial, where we're really trying to prove this out in a way that's suitable for publication and for kind of a deep dive. In a commercial setting, we're asking people to do a blood draw before they begin Virta so that our physicians and their physician can take a look at their baseline metabolic factors. So it's pretty simple blood panel, pretty standard blood panel. We also ask people to do an EKG so that we can check for their cardiac health. And then what they're monitoring on an ongoing basis is a few things at home and then a few things that we ask them to do as a follow-up laboratory test. So at home, they're getting daily weights off a cell-enabled scale. They're also monitoring both glucose and ketones through a finger prick blood test on a daily basis. And they're inputting into that information into the app along with some indicators of their behavior change. And now in the clinical trial setting, we're asking people to do, much more. That's where we're doing things like carotid ultrasounds and DEXA scans and advanced blood testing.
And you recently published a big paper in a journal, didn't you, as a company, or from the research that you guys have been doing?
Yeah. So we undertook back in the summer of 2015 the largest clinical trial to look at a remote care and nutritional ketosis combined therapy for type 2 diabetes and prediabetes. And so this enrolled nearly 500 people, and we worked with Indiana University Health on this trial. We now have all of our patients last year past the first year of care. And so what we did for this publication in Diabetes Therapy was to summarize kind of all the information on our patients at 1 year and share those results. We now have other publications underway, including one in Press on cardiovascular outcomes, another paper submitted on liver outcomes, and we'll be reporting the 2-year outcomes of the trial as those become available. But the paper in Diabetes Therapy on the 1-year type 2 diabetes outcomes really looked at a couple things and had a couple main points. It looked at 262 people with type 2 diabetes who selected the Virta therapy. And then in a non-randomized way, we had another 87 people who were getting the usual care, working with an endocrinologist and a certified diabetes educator. And we were not intervening in their therapy. They were just being monitored to see kind of how do people typically do in central Indiana when they have diabetes over a year. And so both in our Virta treatment setting, as well as the folks on usual care, were fairly sick. They were average time of type 2 diabetes of 8 years, average age of mid-50s, obesity, average BMI of 40 in our intervention group. So people coming in with a fair amount of metabolic disease. What we showed with the Virta group was that we were able to retain a high percentage. So 83% stayed with the intervention for a year. The hemoglobin A1C was reduced 1.3%. And so that meant that 70% of people were able to get in the sub-diabetes glycemic control range. And 60% of people were able to do that without any specialized medication. So removing all diabetes medications except metformin, 60% of people were able to achieve glycemic control off meds. They lost on average 12% of their weight, so about 30 pounds. And so those were kind of the main outcomes, were glycemic control, off medication, and with reduction in weight. And then a whole series of other biomarkers that I mentioned. We've demonstrated improvement in inflammation and dyslipidemia. Now, one thing that's kind of important to note is that a 1.3% reduction in A1C may sound like a small amount for people who aren't familiar with the field, but it really is. The way that I think about it is it's really 100-fold better than what we see with usual care. And our usual care, our small usual care group, was pretty typical of what's been reported by others, which is that type 2 diabetes rarely goes into remission. So Kaiser had a study of over 100,000 people where they reported a 1-year remission rate of type 2 diabetes of less than half of 1%. Whereas we're seeing, 70% achieving glycemic control, 60% doing it off of medication except metformin. And so that's really 2 orders of magnitude better than what you might expect to see under usual treatment.
So this is, I guess, is there not much research around nutritional ketosis or low carbs for diabetic management, and you are doing the forerunning research to show that it is okay for type 2 diabetic patients to eat low carb?
Right. So the low carbohydrate approaches date back really millennia. In terms of the most ancestral diets were lower in carbohydrates than a typical Western diet today, and there were diets for certain peoples that were ketogenic or ketogenic for at least part of the year. And the diet has been, promoted for weight loss since the mid 1800s with Banting. Mm-hmm. And so it kind of has this long history. But in terms of more recent biomedical research, there are kind of a couple of key highlights along the way. One is in the mid 1970s, Bruce Bistrian, who's one of our scientific advisors for Virta, showed that he could take people with type 2 diabetes on insulin, bring them into a hospital setting, and by reducing their carbohydrate using a protein-sparing modified fast, rapidly remove insulin and remove insulin resistance. So he was able to effectively reverse diabetes by carbohydrate restriction. Now, that's not a sustainable approach because he was restricting calories in the process as well. And so one of the innovations that we've done is to say, rather than having somebody go on a caloric restriction diet, like a shakes or something like that just remove carbohydrates but don't provide sufficient calories, is that we actually teach people to eat a higher fat diet from the beginning. So they're shifting away from carbohydrates, but we're not doing it in a way that promotes caloric restriction. So that's one difference. And then if you look at more recent studies, there have been a whole series that have been done by our co-founders, Steve Phinney and Jeff Volek, looking at people with metabolic syndrome and with prediabetes, and small randomized trials run by Laura Saslow and Rick Hecht out of UCSF, looking at the treatment of diabetes. But these were smaller trials. And so the kind of things that are different about this Virta trial with Indiana University Health are, one, is that we've gone from kind of dozens of people to hundreds of people. So we've scaled it an order of magnitude. And then the second is that we've learned how to do it remotely. So rather than having people have to come into the clinic for their education and follow-up, we're able to do that through a telemedicine approach.
Yeah, and that's so handy. I'm just thinking where, people like to travel, people are busy in life, so it's hard to get to doctor's appointments. And the benefit of your service is this is all done through an app on your phone that we're talking about, or text messaging through your phone.
Right. A couple of points. One, we wanted to show that this actually was indeed the case. And so you could argue that more in-person touch would be required to have these kind of beneficial effects. So in the trial, we actually set it up to test that. People could opt in. It wasn't randomized, but our patients who were in the intervention arm of the trial had to select between two modalities of intervention. One was that they could opt for the entirely remote approach. So they get the physician and the health coach and the online nutrition and behavior change education, the biometric feedback, the online community, but it's all done, via phone and via remote. The other arm of the intervention was to provide all of those things, but also to have people come into the clinic for classes with the health coach and 10 to 20 of their peers in person, and to start out doing that every week, and then the frequency drops off so that it becomes every other week and then every month. And what we saw was that the results were indistinguishable, so that both groups did very well. And it didn't appear that the classroom was adding efficacy.
That's interesting. Yeah, so you would suspect that in-person might have a higher success rate just because there's maybe more motivation and people can sort of hide away doing things remotely, but you're saying the motivation and the follow-up procedures are in place that people do sort of stick with it and get the benefits from this.
Yeah, and so and we can hypothesize as to why that is, but I think that a couple of things were necessary for that to be the case. One is this connection with the health coach, so you really have an expert there who you can trust. The second is that the online education that we provide is outstanding. So people are really learning the key kind of things that they need to know to navigate our modern food environment, where you're trying to acquire your macronutrient contents in a very different way than most people do, which is challenging. And so, but we're doing a very good job of teaching people the life skills to do that. And then the third thing I'd say is the biometric feedback. We believe is an important component. So people are measuring a number of things on a daily basis. I mentioned weight. They're also measuring glucose and beta hydroxybutyrate in the blood, so a marker of nutritional ketosis. So people know on a daily basis, am I achieving nutritional ketosis or not? And, if not, then what changes might I need to make, in order to see a better result the next day? And then they're also reporting on mood, energy, hunger, and cravings on a daily basis on a 4-point scale. And so people kind of are thinking back, okay, over the last 24 hours, was I having more cravings, or was I feeling, more restricted in my energy than perhaps I was on a prior day? And so that's all information, that's helpful for the patient as they think through the challenges of success. It's helpful for the coach, the health coach, in terms of monitoring the outcomes. And then it goes also into a data science component, which is behind Virta Health. So there's a whole layer of software and data science and data engineering that's helping us to prioritize patients. And so those daily markers of success are very important.
Okay, so you're kind of getting people excited about biohacking and being quantified self-monitoring on themselves, and demystifying numbers and not making it too hard or too scary or not understandable.
Yeah, I think that it's as you mentioned, I have been doing quantified self for a while. And, I think that's great for people who are really into it to kind of dig in and, read a lot of papers and figure out how to do their own self-testing. What we try to do at Virta is like you said, demystify all that. So we're trying to basically say, let's make this very, simple for people. And so, let's make the feedback loop informative. Let's measure something that matters. Let's present the data back to people in a way that's easily digestible for rapid decision making, so that they're not having to kind of invent the whole biohack themselves. They're being provided with the finished product.
Yeah, so they've got a template, and as long as they just input the right points, then you can assist them and do it sounds very, very Silicon Valley, data mine them and help assess them and know who's maybe going in the wrong direction at higher risk, and you need to maybe ping a health coach, I guess, to intervene a bit more. Is that the kind of information?
I think that, the sort of Silicon Valley kind of part behind this is that as we scale the intervention, it's easy for one health coach to do that with a small number of people and look at the raw data themselves if they have a small number of people. But as you want to try to scale that intervention and have one health coach take care of hundreds of people in a very effective way, you have to make it easy for that coach to rapidly prioritize their patients and know that the intervention they're providing, which can be as simple as a text message, but to know that actually is efficacious. And so having a whole layer of data science behind you. And so in the same way that there's a user interface for the patient, the app, there's also a user interface for the clinician, both for the health coach as well as the physician.
And when you were talking about the taking your own sugar levels, your glucose levels, and your ketone levels, do you, as a company, provide the patient then with a monitor, or do you end up recommending a monitor to them? Because it sounds like they have to have a monitor to be able when they enroll in the system.
Yeah, we provide a monitor that's part of a starter kit that comes in the mail to anybody who enrolls in Virta. And there's a video on our website of one of our patients, Wilma, and her patient journey. And so you'll see in that the establishment of her relationship with her physician, Jeff Stanley, and her health coach, Catherine Metzger. And they also show Wilma opening this box, and that box essentially is the starter kit for Virta, and it includes things like the glucometer and ketone meter.
Okay. Because people already be thinking, oh dear, what happens if I don't have one? Can I actually do this? But
we provide that. We provide the disposables as well. So we will, resupply when people have used up all of their glucose and ketone strips. They'll just tap a button in the app and it resupplies.
Okay, that's cool. And when you were talking about nutritional ketosis, and we've been talking about insulin resistance too, because I've had, Dr. Ben Bickman on, and we had an interesting point there about nutritional ketosis and the magic number of 0.5. Mm-hmm. And he was saying recently at the Low-carb Breckenridge that it was being talked about that maybe we don't have to achieve 0.5 to say the word nutritional ketosis. Is that also what Virta is following, or do you want the patients to be 0.5 millimolar and above with their ketone levels?
That's a great question, and I agree with Ben that it's a bit of an arbitrary number. And what we saw in our clinical trial was that at 70 days in, our average laboratory measured ketone value was a bit over 0.5 on average, so 0.6. And then over at a year, it falls a bit where it's closer to, I think 0.38 or 0.4. And so not everybody is in quote unquote nutritional ketosis all the time in terms of being above 0.5. But if you look at a population that is not restricting carbohydrates, their level of beta hydroxybutyrate in the blood will be somewhere between, just above 0 or perhaps 0.1. And I think in our clinical trial, it was 0.17 or something like that. So out at a year, although people may not be at this magic number of 0.5, they're double or triple what they would be if they weren't restricting carbohydrates. And so I think that there is likely a sliding scale in terms of the degree of benefit. So perhaps to get some of these hormonal or signaling effects of ketones, you might need to be up above 0.5, and that's kind of where that number comes from. It's from animal studies. What levels do you need to be at to see some of these hormonal effects? But even if you're not achieving that all the time, you're still substantially using fat for fuel, fueling brain cells with ketone bodies, and seeing benefit. So we see that our patients who are achieving elevated ketone levels are succeeding, whether or not they're hitting this magical 0.5 number or not.
Okay, so because that was the interesting point we touched on. That I also felt that once you go into the low carb rabbit hole and you start researching ketones and everything, that there could be a bit of a pressure thinking I have to achieve this 0.5 number, and especially a patient who's already metabolically sick and trying to get well, I guess they might feel more pressurized to try hit that 0.5 number, but it sounds like they don't have to. As long as they're making ketones, then they're moving in the right direction, and Virta will be happy.
Yeah, so the health coach is establishing a relationship with a patient that includes both this kind of very informational feedback loop, but also an emotional feedback loop. And so when you're coaching someone, you have to kind of have the nuance of understanding what does that person need to succeed. And so part of that is saying, hey, look, we're gonna figure this out. And if somebody, like, for instance, is getting a ketone level of 0.1 or 0.2, and they're several weeks into the program, there's probably something that they can do better in terms of their nutritional choices. So, for instance, one of the things we find are hidden carbohydrates. So carbohydrates that are sneaking into a meal that you may not realize. So just to give some examples would be, an overconsumption of nuts, if you're having nuts as a snack, and particularly something like cashews. People think about that as nuts, but they're actually seeds, and they're actually relatively high in carbohydrates. So just having a mixed nuts that has cashews, that can be your trip up. We also find that people will tend to overconsume protein. So we recommend a moderate protein diet. Protein can be converted, or some of the amino acids could be converted into glucose by gluconeogenesis. And so that also can result in, blocking nutritional ketosis. And so sometimes what the coach is doing is saying, okay, what might it be in your dietary choices that could lead you to a greater degree of success. But then also it's being patient with people and being supportive of people, and knowing that not everybody has to have a high number all the time.
Mm-hmm. And so is that, from what it sounds like too, are these some of the goals that you give patients? So they originally would come just to say, I want to feel better, but you give them sort of these measures like, has your waist circumference come down? Has your hip to waist measurement ratio improved? Your glucose numbers are better now. Ketones are a little bit up. Are these some of the like goals that you would educate people or give them to say, hey, look, you're making progress with our system?
Yeah, exactly. So the coach is working with people to individualize the treatment offering. And that's another kind of lever of technology, is that we can make it work in many different settings. So we're not recommending sort of a one size fits all approach. The nutritional recommendations are individualized for people's metabolic health, also for people's dietary selections. So if somebody is cooking a lot of meals versus somebody who eats out a lot, somebody who is cooking just for themselves versus cooking for a large family, or different religious and ethnic backgrounds, different food choices, like vegetarian, we can adapt our recommendations to suit, all of these different individuals.
That's interesting. So yeah, it's not just one set prescription. You can work with lots of different nutritional lifestyles that people would like to follow.
Yeah, exactly.
And just to optimize it.
And so the health coach then is also selecting different modules and saying, okay, we're going to focus on glycemic control for the next few weeks, or we're going to focus on ketone production for the next few weeks. As people get further out in the Virta intervention, in the Virta treatment, things shift from this kind of factual relay of information to make sure that you're making, the right nutritional recommendations. Things get more diverse the further out you go. So we begin to concentrate more on other factors like exercise or sleep, or stress. And particularly as we get out beyond 6 months, people have largely figured out the nutritional ketosis part of things by then. They know a lot. They've kind of gotten a graduate degree education in nutrition by that point. But what they need help with are things like psychological issues like depression or stress, or life events tend to be quite important. So somebody might be on track, but then there'll be a disruption, a loss of a job, a death in the family, a move, or it could be even a beneficial thing like a marriage in the family. But anything that results in people kind of taking their eye off of their own health and prioritizing something else in life, they'll need to reset if they've gotten off track. And so we're troubleshooting these kind of larger life issues. So as we get out beyond 6 months, it becomes in some ways more of a life coach as opposed to a nutrition coach.
Yeah, that's what I was just about to ask, because to then start coaching people with how they can optimize their sleep and how that affects their health condition, psychological things, best way to exercise. Wow, and this is all that will keep carrying on with the service once they get to a particular level.
Yeah, so we've designed Virta to be a continuous intervention, so that the treatment initially we're looking at 1 year, and we ask people to make at least a 1 year commitment when they join Virta. So we're not interested in coaching somebody for a month, or providing the treatment for a month. So a year, and then out beyond a year, we offer Virta on an ongoing basis. And it's a reduced price point for the second year and third year, because the treatment is less,
intensive.
Intensive. Thank you.
Yeah.
But our corporate clients are building that into their contracts. So they're selecting, yes, I want to keep people with this for, a second and third year.
Well, I like that, because people will need continual coaching, and as you said, lifestyles change or situations change. And I guess what's another benefit I'm hearing here is that they're able to have access to a health coach and be able to say, hey, look, this is going on in my life, and maybe now because I'm educated on all these other biomarkers, I can see something's going wrong here, or I'm starting to fall into a bad habit. And this is where you can have that touch point and then try to steer them back onto a better path so that they don't fall back into that bad metabolic state again.
Yeah, that's exactly right. Yes.
Okay, great. And I guess we haven't touched on the one part, but as with any new enterprise or venture, there are some criticisms. And I was trying to just do a little bit of research as to why would someone not like Virta. So I'm sure you've come up. I'm sure you've seen some of these, and I did find it interesting that there is one particular doctor online who I read that he's saying how Virta has a canary in the gold mine, or in the coal mine here, and that low carb diets create more deaths in the long term. So it's quite inflammatory in one hand stance. And I just wondered, do you have sort of some answer or way that you would say no, don't worry, being on a low carb diet, you're not going to die early?
Yeah, I think there's no evidence for that. That kind of dates back to the diet heart hypothesis of the 1950s, and this idea that saturated fat would raise cholesterol, which would result in clogging of the arteries, which would result in a heart attack. And we know mechanistically that that's not correct, that there's actually there's one meta-analysis showing that saturated fat is not a risk factor in either cardiac death or overall morbidity and mortality. Second, that the cholesterol component of this hypothesis is all messed up. There are people with low cholesterol that die of heart attacks. There's people with high cholesterols that are, very healthy. And we know now that the better markers of cardiac disease, heart attacks and strokes, is actually insulin resistance, shown by type 2 diabetes, dyslipidemia, waist circumference, obesity. All these markers that trend with insulin resistance are actually the best correlated markers for cardiac disease. And so I think there's really zero indication that he is correct.
Mm-hmm. I'm sure you've read that article. So
yeah.
And another, when you were talking earlier about a vegetarian or vegan, I'm going to have a guest on who is a keto vegan, and I haven't done too much research myself with that, but that would be interesting. How do you minimize excessive carbohydrates when you're a vegetarian? Has that been a challenge for Virta?
Yeah, there's a blog post on our website. So if you go to virtahealth.com/blog, there's how to do Virta as a vegetarian or a vegan. There are quite a number of patients who are vegetarians. There's quite a number of Virta employees who are vegetarians. And so that tends to be relatively easy to do if you're eliminating meat, but are able to include other sources of protein and fat in your diet. It's a little more tricky for somebody who's vegan, but it's doable. And I think Carrie Dialis in Ohio is a physician who's a vegan ketogenic person. Who
she's going to be my guest coming up.
Oh, awesome! Yeah, so she has some. She's provided a lot of information on how she does that. It gets a little more tricky in terms of making sure that you're getting, adequate fat in the diet and adequate micronutrients. But it is very achievable.
Okay, and with Virta now having access to all these biometric markers, I would love to know: are you going to be doing? You mentioned you've got in publication the cardiovascular one coming up, because when everyone, well, as you're probably aware, there's a lot of people who go low carb, more higher fat, healthy fat, and their cholesterol numbers do change. And so you're going to have data now to interpret that a bit more, or maybe even use the information like Dave Feldman is finding out about cholesterol. Are you going to sort of end up doing more data mining in that sense there?
Yeah, so we've already reported in the paper that's already published in Diabetes Therapy, sort of the standard lipid panel of HDL, LDL, total cholesterol, triglycerides. What the next paper does is it uses the data from the NMR lipo profile, as well as reporting ApoB, ApoA1, and we're able to look at all the various ratios. And so what we're generally seeing is that the atherogenic dyslipidemia is resolving, and that's shown by a reduction in triglycerides and a rise in HDL. We also see concomitant with that rise in HDL, a modest rise in overall cholesterol and LDL. And so, but the next paper will largely show is that is a beneficial change in terms of the way in which all of the markers are moving in terms of the subfractions of LDL. So, in general, we're not concerned about the rise that we're seeing in LDL in the context of all of these other beneficial changes. And largely, I think that recent papers have shown that LDL in isolation is not a particularly good marker for cardiovascular disease. That these markers, LDL particle number, or ApoB or ApoB to ApoA1 ratio, as well as just the markers of atherogenic dyslipidemia, are much more important in terms of cardiovascular health.
Well, I think it's going to be nice that you're going to have data to help people see that I'm guessing it's a little bit random at times, where you'll have a percentage of people who will, as Dave Feldman says, are hyper responders, some who aren't, some who are. And as you build up more data, you'll be able to and data mine using the Silicon Valley method, go like, oh yeah, we can see if someone does this, they tend to fall into that category, or if they do this, they fall into that category. But we can look at other metabolic markers and go, it's okay, it's fine, you're not going to put yourself at risk here. And this is again, I can see another benefit now. I'm just thinking off the top of my head that if someone's going low carbohydrate, healthy fat for the first time, through your system, they will have contact with a health professional who understands the diet, and if they get a blood test back and it's come back with higher cholesterol and they stop freaking out, that they have a point of contact to go, am I doing the wrong thing, right thing? I'm scared now. And you'll be able to give them guidance on that.
Exactly. So having a physician who really understands this is key. And our physician can both work with the patient and the health coach in terms of the interpretation of information. And we also can communicate back to, and we do communicate back to the primary care physician to say, okay, here we're 6 months in or a year in, and here's the results that we're seeing, and here's our interpretation, of those results. And in general, the primary care docs are super excited about the results that we're achieving, that they're seeing that their patients are much healthier, and so they, if they start skeptical, they become fans after 4 months or 6 months into the interaction with Virta. I think that it's interesting you brought up the work that Dave Feldman is doing. I think that's probably the best example of a quantified self-experiment that's really changed the knowledge base of biomedical science. And so what I would hope is that folks who are in the lipid field would take a look at Dave's work and replicate that in a formalized clinical trial with larger numbers of individuals, and because I think that what he's shown anecdotally and with just sort of N equals 1 and then N equals, I forget how many people he's had that he's gathered data from, but it's been done in an informal way, and what he's largely shown is that people are using fat for fuel, and that's the main driver of the lipid profile in the context of ketosis, is not a dyslipidemia, but rather an indication of how people are driving their metabolic fueling of the body.
So I'm sure everyone listening to this right now, if they do have some sort of metabolic condition and they live in the US, they're pretty excited because they want to sign up for the service. Do you have any particular? I'm sorry. Are there like different packages that come with the service? Do people's healthcare insurance cover these, or is it an out-of-pocket expense?
Yeah, great question. So for employers who provide this as an offering, or health plans that provide this as an offering, it's what most employers have decided to do is provide it as a fully covered benefit. So for people, for instance, at Nielsen or Purdue University, they're receiving this, from their employer. They're not having to pay additional out of pocket, and they're not having to worry about sort of every time I'm in touch with my health coach, there's an additional charge or something. It's all just one lump sum, one package. For direct to consumer or direct to patient, it's on the order of $370 a month for the first year, and then it's reduced for the second year. And currently, that's out of pocket, but we hope to see that changing as insurers come on board. And so we're working with the employers and health plans first, and then moving into having this as a covered benefit through insurance. And so I think that's what you'll see kind of over time as our levels of proof become even better. And as there's more of a track record of working with payers.
And you need numbers at the end of the day for insurance companies, because that's what their data guys need to then go, okay, actually this financially is better for us to fund this versus something else. So we will cover this.
Exactly.
Yeah, that's great. So Jim, what are the ways that people can either keep following you or get in touch with Virta?
Sure. So the website is virtahealth.com, and we have a blog that is coming out with new articles every week. And there's a sign up. If you just start reading one of the blog articles, it'll ask you, do you want to sign up? And you can provide your email and get on our mailing list. We're on Twitter at Virta Health, and I'm on Twitter at JP McCarter. And so I'm generally tweeting about things related to nutritional ketosis, as well as telemedicine and other kind of issues that are relevant to Virta Health.
Great. And as I mentioned way back at the beginning of this, you're a fan of Quantified Self, and I have an idea of having a follow-up podcast to this to talk about your own personal health story and what you've discovered. I think that would be fascinating because you've been doing long-term ketosis too. So I'd love to maybe pick your brains about that and what you've discovered.
Yeah, I'd be happy to talk about that. And that was part of my journey that resulted in my joining Virta 3 years ago, was this personal experience. I was several years into nutritional ketosis by that point already. And so I had an idea of the metabolic changes I'd seen in myself, and believed that we could demonstrate in a large-scale clinical trial that this worked not just for N equals 1, but N equals first hundreds and then thousands and eventually millions of people.
Well, I look forward to picking your brains on that one to share those knowledge bombs with everyone.
Excellent.
Great. Thanks so much for coming on.
Thank you, Gary. Really appreciate it.